I'm Pascal-André Vendittoli, co-founder of the Personalized Arthroplasty Society with Charles Rivière and a true believer in patient-specific and ERAS surgery. As it was presented by Charles, it is now the end of a one-size-fits-all technique. We need to abandon the MA dogmas to improve our patients' function and satisfaction. In 2011, Stephen Howell convinced me right away that resurfacing of the knee joint was the solution to improve my patient outcomes. His KA is a true revolution for knee replacement surgery. So why did I propose the restricted kinematic alignment? In this paradigm change from a systematic to a personalized surgery, before reproducing all anatomies, two main questions need to be answered. First, what is a normal lower limb anatomy? Second, what anatomical parameters are compatible with the current implant material and fixation methods? We've been thinking about this for a long time, and we are far behind in orthopedic surgery. I found this paper published in The Lancet in 1947. How can we define what is normal? First, we can look at the statistical distribution of the values. Secondly, we can only consider value to be abnormal when they are linked to a disease process or a dysfunction. Let's start by looking at the statistics. Hirschman and colleagues analyzed 11,000 lower limb CT scans of patients with knee OA and patients without OA. As you can see in this graph, the two populations have near normal data distribution, but with different means. In a normal distribution curve, we could define normality as plus minus 2 standard deviation from the mean, abnormality more than 2 standard deviations, and deviance or aberrance above 3 standard deviations. But being away from the mean, is it linked to a problem? In the human diversity, we see individuals with very extreme characteristics, but without any pathology. A more valuable way of classifying the normal from the abnormal values would be to use a cutoff linked to an increased odds of a disease or adverse event. Let's take the blood pressure example. It is well known that high blood pressure above 160 of systolic is linked to an increased risk of stroke, heart disease, kidney disease, or visual problem. Similarly, for the hip, we know that some parameters, like the Weiberg angle of less than 20 degrees, will lead to joint degeneration. Please look at these radiographs. How rapidly this dysplastic hip progressed to a severe OA. Neck remodeling is also very impressive in only 3 years. Surprisingly, on the knee side, there is a very important void of science and data. Very little is known regarding the link between anatomical parameters and future joint degeneration. After more than 50 years of joint replacement research, we still do not know what is a normal and what is an abnormal knee joint. We still do not know if we should replicate all knee anatomies. Secondly, a TK implant is not a natural knee. We do not know if the actual implant materials and fixation methods are compatible with all anatomical parameters to provide a long-term implant survivorship. That is why we should question ourselves. Should all patient anatomy be reproduced when performing a TKA? As we know that polywear increases with cup abduction in hips, we would never replicate the acetabular dysplasia with our implants. I believe it is the same for the knee. So the question is not should we have boundaries? The real question is what should be the boundaries? In 2011, I proposed a restricted alignment protocol. I would like to review the 5 principles of its fundamentals with you. I propose these principles based on patient anatomy description. The first principle is the HK boundary of plus minus 3 degrees. This number was selected based on 2 factors. First, to include more than 2/3 of the patient without any modification. Secondly, these numbers were not associated with the decreased implant survivorship in MATK history. If we look at the patient anatomy more in details, we observe that the mean distal femoral angle and the mean proximal tibial angle are approximately 3 degrees. There were also around 20% of the patient with anatomy above 5 degrees. As a second RKA principle, I suggested to limit the tibia and femur joint orientation to 5 degrees. This limit corresponds to the mean value plus minus 2 degrees. as you can see on this graph. We looked at the bone anatomy, but soft tissue and ligaments are also very important. Most anatomical studies agree that the collateral ligament tension is subjected to individual variability, but in general, female are looser. MCL is tighter than LCL, and both collaterals are tighter in extension than in flexion. The key point is that in a native knee, collateral ligaments are not isometric. So restoring normal ligament laxities will favor joint kinematics and correlate in clinical study with higher patient satisfaction and better clinical score on short-term follow-up. Thank to Indeli's group for publishing this great paper. So our third RK principle is to restore native knee collateral balance in laxities versus aiming for ligament isometry. We should avoid all gap balancing related technique to modify bone resections. Next question to answer: when anatomy adjustments are required, where should it be performed? On the tibia, the femur, or both bones? We know that the key of the knee joint kinematics is the femoral anatomy. Maintaining its flexion axis orientation and joint surfaces anatomy is a priority for RKA. This is our fourth principle. When performing anatomical modification to reach our RKA thresholds, we should favor femoral anatomy preservation. The fifth and last RKA principle is to resurface the intact compartment. It would be the lateral compartment for a varus knee as example. Doing so, I'm sure to preserve the joint line level and will be in a familiar situation if I need to perform ligamentous release on the disease compartment. To simplify the decision making, here is the RK alignment algorithm to follow for each patient. This algorithm follows our RK principle and favor patient phenotype preservation, as adjustment will be performed on the most contributing bone to the deformity. Beyond determining boundaries, I can affirm that in clinical practice, we are facing complex cases which need specific considerations when trying to perform a personalized surgery. With my colleague Charles Rivière, we tried to summarize in a personalized arthroplasty classification these cases in an effort review publication. Even if the restricted protocol includes the vast anatomical variations, it was not designed to take in account specific situations like acquired extra-articular deformities. Another pathological situation occurs when the peri-articular soft tissue have been severely modified by the disease process. Severe windswept deformity, like this one, require a constrained implant on the right knee and a hinge on the left. We are far away from a KA technique. And last, aberration of the human being are unrelated to their particular bone anatomy. With the same skeleton, you can face different limb morphologies. You all encounter patients with valgus alignment and associate very large lower limbs. These patients are not very happy if you keep their knocking knees. Knee resurfacing for these cases will maintain a thigh friction and may be unsatisfactory to the patient. I proposed in 2011 the restricted K alignment protocol and published different papers reporting the clinical results with cemented and uncemented implant. But the most important result is the patient satisfaction. With 95% of the patients satisfied, we are way above 80% reported with MA. In another study, we obtained a mean forgotten joint score of 77, which is much higher than the result obtained with MA-TKA, where most studies report a mean of 55 to 65. So what is the personalized arthroplasty? It is still an evolving concept. In my point of view, there are four main pillars. First, we should meet patient expectation. Second, we should offer a patient-specific perioperative care, minimizing adverse event and optimizing recovery. Third, it is the quest for the forgotten joint, which involves anatomy and function restoration, accurate surgical technique, and improved implant design. Last, we want to offer a lifelong implant survivorship to our patients. I believe that RK is the ideal compromise to achieve these goals while avoiding reproducing pathological anatomies and keeping the lower limb alignment in a safe range compatible with implant long-term survivorship. Keep in mind that boundaries will certainly evolve over time, but I'm sure that restriction will persist. Moving away from systematic technique, we are in a period of healthy debate to define the ideal personalized arthroplasty. I suggest you read these two editorials published in KSSTA in 2024, one by Stephen Howell's group, supporting unrestricted KA for all, and the other one by our group, considering that pathological anatomies exist and proposing restrictions. Compromise and negotiations are part of and parcel of life. Science will evolve with experience and debates and emerge from consensus.